So let's take a quick look at the issues of aging as it relates to neuroendocrine functions. The first thing we have to look at is with the sex hormones. We have a rhythmic regulation that begins with fetal development. All fetuses will begin development as a female, or what we refer to as the neutral morphology. During fetal development, a spike will occur in testosterone in males. This spike in testosterone leads to sexual differentiation in terms of morphology, and then we get normal rhythmicity throughout maturation and into adulthood until middle age occurs. So when we look at this reproductive spike, for males we get a secondary spike post-fetal development at about 13 years of age plus or minus 2, somewhere to 17 years of age plus or minus 4, with a cyclic high and low throughout middle ages, where we start seeing a decline of about 1.5 to 2% per year starting at about age 45, with truncation at around 60 years of age, with a reintroduction somewhere in the neighborhood of 1 to 2 years after that. For females, we get a spike in reproductive hormones at about 11 years of age, plus or minus 3, to upwards of 20 years of age, plus or minus 5, with cyclic highs and lows throughout middle age. For the females, estradiol, or estrogen, will tend to hood aspects of metabolites and other anabolic hormones that limit the reactive oxidative species depositing within vasculature and can counteract any damage issues that are associated with high aerobic metabolism. A dysregulation within the reproductive hormones begins uh, for both genders in the fifth to sixth decade of life. For males, at about 60 years of age, we get a truncation or a retardation of responses globally to all androgens and anabolic hormones. For males, this starts to kick back up, where they start to respond once again, about 1 to 2 years afterwards. At which point in time we have about a 60 to 70% responsiveness in terms of levels that used to be present. And then we get a decay and decline of about 2 to 5% from that level per decade over the next 2 decades. For females, we get a truncation at about 50 years of age, where we get a retarded response globally to androgens and estrogens, and a rather large spike in FSH levels. It's this rather large spike in FSH levels with a truncation of androgen and estrogen responsiveness that leads to the onset of menopause. The actual onset age is influenced by the total number of pregnancies that a female will have. For other anabolic hormones, such as coming from the pituitary, there's going to be a decrease in HGH, TSH, and gonadotropins with older age. When we're talking about older age, we're talking about beyond middle age. Some of this has been misinterpreted to lead to the development of quote-unquote anti-aging medicines, where they prescribe HGH, prescribe TSH, or prescribe gonadotropin hormones. The problem is that unless the tissues are being stressed with physical activity, where we have to keep anabolizing the tissues, keeping building the tissues, it doesn't matter whether we produce these hormones in large amounts. That's the principal reason why we see a decrease in these hormones. From the thyroid hormone, we're going to see a decrease in both T3 and T4, particularly with very old age, and especially when we start having limited activity with older age. The decrease in T3 and T4 is one of the reasons why older individuals tend to constantly be cold, because they do not have the increase of thermogenesis coming from the mitochondria within the tissues. From the pancreas, we get a decreased response to glucose changes. The decreased response to glucose changes is principally seen with a change in insulin secretion and insulin sensitivity. We're going to take a look at how this occurs in a couple slides here, but it is associated with both age and poor diet, along with drastic inactivity. So what are a couple other issues that might occur with neuroendocrine functions? Well, one of the things that happens is with doping and ergogenic aids. So ergogenic aids and doping are basically supplements that you can consume that mimic how hormones work in terms of metabolic functions. There are tons of anecdotal reports and accounts for this supplement works, that supplement works. However, there is very little empirical evidence to show that most of the things that are sold in the quote unquote health food stores actually work in the way in which they are advertised to work. And some of them can become very toxic and very metabolically counterproductive to normal tissue functions. So let's take a look at the diseased state. When we look at the disease state, we're basically looking at a dysregulation to hormone sensitivity. It's linked to age, linked to adiposity, being over fat, and linked to disuse issues, meaning that you're not active. The typical diseases that we look at here are cardiovascular disease, CVD, type 2 diabetes or metabolic syndrome, and both of them are linked with obesity issues. So we start with the interaction between an increased caloric balance, a reduced physical activity, and an increase of age. These all lead to a decrease of anabolic hormones, an increase of binding globulins for those anabolic hormones, an increase of relative stress, an increase of stress output, the HPA. The reduction of anabolic hormones, the reduction of physical activity, the increase of age leads to a reduction of basal metabolic rate, a reduction of lipolysis, and a reduction of protein synthesis. This couples with the increased caloric balance leading to an increase of visceral fat. The increase of visceral fat causes a change in hormone signaling, leading to a secondary increase of HPA access. We get adipocyte differentiation, a change of cytokines leading to greater disruption of both the anabolic hormone issue as well as the stress issue. The stress issue leads to an increase of C-reactive protein within circulation. At peripheral tissues, we get an increased expression of metabolic syndromes, a reduction of insulin and leptin sensitivity, and a change towards what's referred to as a pro-inflammatory setup, meaning that we're more likely to have inflammation occur. The metabolic syndrome issue, the insulin and leptin sensitivity issue, leads to an increase of blood glucose and a compensatory hyperinsulinemia, meaning that the person is usually referred to here as being quote unquote pre-diabetic. The increase of inflammation plus the increase of stresses leads to an increased immune response, in particular within the bloodstream, leading to atherosclerosis and a reduction of arterial compliance. The combination of the C-reactive protein with the decrease of arterial compliance and the atherosclerosis leads to the increased relative risk of cardiovascular disease. So we have the change of metabolism leading to type 2 diabetes, and we get the change of inflammation within the cardiovascular system, leading to cardiovascular disease, all linked to the changes of physical activity, aging, and caloric balance. We can't do much about the aging issues. However, we can go ahead and change those other two factors that are going to lead to the dysregulation. So physical activity and changes of diet will alter those cytokines, those hormones being released by adipose and skeletal muscle tissue. All of this leads to the reduction of inflammatory hormones, a normalization of leptin signals. Leptin, it has the abbreviation OB, and adiponectin signals. Adiponectin has the abbreviation ADIPO. These changes towards normalization reduces the cardiovascular disease, changes cellular metabolism energetics to make the person more metabolically sound, and reduce the risk for type 2 diabetes. It changes both the HPA, the adrenal axis, as well as the HPG, the gonadal axis, dysregulation, leading to a normalization of stress hormones as well as a normalization of gonadotropin and responsiveness to androgens and estrogen. This has a continuum of effect where resistance exercise, lifting weights, tends to be more beneficial for the person once dysregulation has occurred than endurance exercise. So let's take a look at that same schematic that we looked at before, but this time let's look at it with a change of activity. So we have an increase of activity where we have both resistance and endurance activities going on. These decrease the stress, which decreases the C-reactive protein. We have a caloric restriction either through increase of activity or through a diet where we end up consuming less than what we were consuming before. We have a shift in all of our anabolic hormones where we have more anabolic hormones and a reduction of their binding proteins. And we have a reduction of visceral fat. The reduction of visceral fat comes from the caloric restriction compounded by the change of exercise, where we have an increase of BMR, an increase of lipolysis, and an increase of protein synthesis. Now we have a reduction of adipocyte activity, particularly adipocyte storage, which means that we're going to change our cytokine signals, our signals coming from the adipose tissue, in which we're going to change from being an inflammatory state to an anti-inflammatory state. The change where we see here is more sensitive to insulin and more sensitive to leptin. We get normalization of blood glucose. We get a normalization of metabolic pathways where we're able to utilize multiple types of fuels. We get a reduction of atherosclerosis. We get a reduction of immune response. We get an increase of arterial compliance, and we reduce that C-reactive protein. All of these compound to lead to a reduction of cardiovascular disease and a reduction of metabolic syndrome, regardless of the age of the person.